And today I am delighted to welcome a very honored guest. Today, Dr. Piotr Oglaza is joining us as our keynote speaker. And Dr. Oglaza is the Medical Officer of Health and Chief Executive Officer of Kingston, Frontenac, Lennox, and Addington, or KFLNA Public Health, and is a fellow of the Royal College of Physicians and Surgeons of Canada in Public Health and Preventive Medicine. He is also an assistant professor in the Department of Family Medicine at Queen's University, and he received his medical degree in Lodz, Poland in 2000, and then completed the Bachelor of Applied Science in the School of Occupational and Public Health with honors at Ryerson University, now called Toronto Metropolitan University, in 2003. Dr. Oglaza then completed a family medicine residency program in 2009 and received his Master of Public Health degree in 2011 from Queen's University. Reminded me that he took classes in this very room. Maybe not this very room, this very building. Yeah. So here at Brothers Hall. So yes, he's a proud graduate of our own department. Dr. Oglaza started in public health as a public health inspector in the Leeds-Grenville-Lanark region from 2003 to 2007. And then after spending several years as a rural family physician within the KFLNA region, Dr. Oglaza returned to public health as the Medical Officer of Health and Chief Executive Officer at Hastings, Prince Edward Public Health, a position he held for more than 3 years before assuming the top job here at KFLNA in 2021. He has helped lead us through the pandemic and on the other side of the pandemic, we hope, and into the future. And he's going to be talking today about public health shifting from response to recovery and refocus. So let's give a big Queen's University welcome to Dr. Piotr Oglaza.
So my name is here. Stand here in Zoom. Thank you so much for this kind introduction. It's really a great pleasure to be back in this building, speaking to this group. Truly, I, as a graduate of this program, Queen's graduate for other programs as well, I was really delighted to be invited to speak to you today on a very important topic. So when we first talked with Brad about sort of what should be the focus today, for the discussion today, we talked briefly about possibly talking about the experience from the pandemic. But I propose slightly a different approach. We've all talked about pandemic, and we'll be talking about this and analyzing this for probably years, if not decades. This was a really a significant incident, event in our history. But I wanted to take it out as a different route, talking about public health in general, and talking about the big picture of public health. And really what I firmly believe is that public health is about looking at that bigger picture, and only once we know the complexity of all the contributing factors, we can devise more meaningful interventions. So this is the cornerstone of public health. It's how we benefit together from that work, and how we can all work towards building healthier communities. As I mentioned earlier, the past 2.5 years or so have been heavily dominated by the demands of the pandemic and pandemic response. So the cornerstone of public health, which is control of communicable diseases, that's how public health started in this province and probably around the world as well. That has understandably received a lot of attention, and rightfully so. We were in the pandemic, but we all know that there is more to health than absence of disease, even serious communicable disease such as COVID-19. So today's discussion is about the work that had to be put on hold during that critical time, and looking forward, looking into the future, looking into what's been done over the course of the past few months, as the demands of the pandemic response have thankfully decreased. as we move from emergency response to routine operations, what are the priorities for KFLA Public Health or public health in this region locally? What do we need to address? We often hear in the media, pretty much every day, we talk about the backlog of care, and that's in the context of acute care system where there's so many surgeries that have to be put on hold, so many other healthcare needs that are not met because of the backlog generated. But what we don't talk about in this context is the backlog of care that occurred in the realm of public health. And today's discussion is going to be about that critical work that had to be put on hold, that is resuming. Some of the work was scaled down because we couldn't completely put it on hold. We were the only show in town to do some of the aspects of public health work, especially in the context of health protection, control communicable diseases other than COVID. That had to continue, but the majority of the resources were reallocated. How we approach recovery is going to be the focus of today. We're scheduled for an hour today. We're not even at the starting point yet, but I won't be talking the whole time. I promise to go through these slides and that initial discussion fairly quickly, and then this will give us an opportunity maybe to engage, talk as a group about some of your thoughts you had about the experience about pandemic, experience about the recovery, and any other thoughts, comments you might have. Let me see if I can.
By clicking it, pull the mouse to the bottom, see if the arrow comes up.
Okay. Oh, all right, it's just the title again. Okay, wonderful. So there was supposed to be a presenter disclosure slide somewhere in between. I apologize, I might have updated this slide slightly after sending it here. So basically, no commercial interest to disclose. I am the salaried employee of KFLA Public Health, and that's my key allegiance at this point. I also take directions, recommendations for the Minister of Health, and thankfully, some of them, over the course of this pandemic, there was a lot of communication both ways with the provincial level, with the Office of the Chief Medical Officer Health. So that's, again, there's no internal conflict there either. Oh my goodness, this is really different. So we missed one slide there too, but I'll talk about that. So let's go back. So what I started talking about earlier is the concept that we have many services that the public may not truly even know what's going on, what work is done by public health, because we stayed in the background, we stayed in this area where if we do our job, nobody really knows about us, and so that something goes wrong, then that gets into the headlines. But as the pandemic started, every public health unit had to make some changes. And certainly that was the case with KFLA Public Health, where to allow that continued response to COVID-19, we reallocated roughly about 70% of our staff into pandemic response. So all the work, can you imagine all the work that was done on COVID, that was on hold, staff were shifted to respond to these priorities. We provided training, we provided basically tools to staff to guide the community. Through this pandemic, we run the call center. We're helping businesses, community organizations interpret ever-changing rules. But that took a lot of staff effort, and that was the 70% reallocation, very similar for other public health units. The one thing that really came out of that is it also helped us build and foster relationships with the community. So some of the sectors that we probably have really never interacted, all of a sudden we're in regular teleconferences connection with us Just basically, this was the need of the day. We're running, we're doing the case contact management at the early stages and throughout the pandemic. Mass vaccination clinic, everything was with partnerships, very strong partnerships, but a lot of the work had to be done by public health. So as we are re-engaging, I already mentioned, we looked at what are the priorities for re-engaging in prior public health work. So when you think about the sort of things we take for granted, the inspections, the safe water, safe food, all of these things are done in the background. All of these things were done at a slightly lower intensity. Some of it was because of many of the premises that we would normally be inspecting, for example, were shut down during the pandemic. But as we recover, we want to make sure that that basic safe food, safe water, safe control of communicable disease, other than COVID, all of these things are immunizations, very important, things that were we couldn't do. And we do a lot of programs such as school-based immunizations, for example, where we couldn't conduct these clinics because the schools were not in sessions. We were doing other things. All of that basic level of protection that we had in the community needs to be restored first. So that's one important element. And then we look at other aspects, other topics and areas where we've seen the negative impact of the pandemic. So we talk about the sedentary behavior, healthy or less healthy eating choices. All of these things were now, over the course of the past 2.5 years, we've seen the message of public health change from, I remember very well, we're trying to discourage public from using drive-thrus, for example. So leave your car, go to, if you have to eat fast food, get out of your car, go into the counter, pick up your food and go. All of that changed over the course of the pandemic. All of a sudden going through drive-thru was a virtue. I remember the days where when I was in medical officer health in Hastings, my predecessor was telling me a story how they went for a meeting and they had to they wanted to stop for coffee, and they actually made a point of getting out of the car because they didn't want to have that public perception of here is the leadership of public health going through drive-thru, which is contradictory to the message that we are communicating to the public. All of a sudden, I'm sitting in a drive-thru, and all of a sudden, I'm super cool because everyone else is doing this, and I'm avoiding contact with others. So that was really one example of many areas where we need to change the behaviors and convince the public now that there's other health risks that are present. So this is a broad slide. This comes from the Chief Public Health Officer report on the state of public health in Canada 2021. So that's very but relatively recent. And it does talk about this. What are the overarching goals of public health? And so that's the portion on the left of the screen. On the right side is where we took. This is where the focus is of KFLA public health. Just speaking about the organizations, I don't know how many of you I see some of the familiar faces, people who've been through this agency, my colleagues, coworkers, but for everybody else's benefit, we are one of the 34 public health units in Ontario. This is our organization comprises of the City of Kingston, County of Frontenac, and County of Lennox and Addington. So this is approximately 209,000 residents. So it's a mid-sized public health unit. Our governance model is an autonomous board. So that's basically, it's a municipally-led autonomous board, which means it is separate from any of the municipal structures, but the majority of the board members are municipally elected councillors. There are provincial appointees, but the balance is the majority are municipal. There's other models of governance in this province, and certainly they all have their pros and cons. I happen to believe that the autonomous, I've only worked in the autonomous Board of Health models. That was the case in Hastings, this is the case in KFLA, and this is really truly the one model that I believe is benefiting our work here. And I think everyone knows here that in public health, we are looking, unlike healthcare system, we're looking at the health of communities. We're looking at the health of individuals, but set in the context of community. So that's really a different focus that even among the healthcare sector, not everyone fully appreciates. Is our thought about health promotion is based on in the context of the population health. It's not the one element of what health promotion might be thought about, might be thought in the context of interactions with the individual patient. Health promotion, message, education for individuals is an element of that bigger bigger concept, but we are looking at this much more broadly in public health. So our key focus here is in KFLA, looking at health promotion, looking at the broader system implications of things that make the default, the preferred choices, the default choices. We are looking at some very specific groups as well. So there's an approach where we look universally at the whole population, but we also have that health equity lens, which leads us to do some intense interventions for more risk population. So that's what local public health does here. And we're again looking at that bigger picture of the community health. The analogy that I sometimes use, that I find it's really appealing to me, at least, it's that when we think of public health, it's the health of individuals. When we talk about health of individuals and relation between that and health of communities, that the analogy with the trees and the forest. The health of individual tree depends on the health of the forest. And in public health, we are looking at that bigger picture. That's what we're doing. So in terms of our mandate, in terms of what public health is locally in Ontario, what the legal framework is, we are looking at the Health Protection and Promotion Act and regulations under that act, which is basically a cornerstone of what we are expected to do. And then there is Ontario Public Health Standards. I have learned that there's not a single public health agency local public health agency in Ontario that is 100% fulfilling all the public health standards. Unfortunately, there's some decisions and prioritizations that had to be made even prior to the pandemic, but that's these documents determine what the type of work we do. Over the course of the pandemic, I'll switch gears a little bit. I talked about the importance of partnership, and this is something that one of the key partnerships that we had in this region, and we've have this really nice sign in our boardroom that was used for some of the Dr. Moskieran's videos. That had the KFL region and all the partners around it. It's like a big circle with basically every single sector you can think of are our partners, are our stakeholders. But I picked here on the relationship between public health and primary care, because that's really what was essential throughout the pandemic and what will be important for our path moving forward. So the collaboration between KFLA and primary care started in the course of the pandemic. We were providing guidance on IPAC. We were discussing the sort of the division of roles and responsibilities in terms of setting up testing for COVID, and talking about case contact follow-up, and discussing the implications of the case or the exposure happened in the setting. But then we moved into a really important partnership with the immunization rollout, and that's really what we're one of the probably one of the few regions with highest immunization coverage for COVID-19 in this province, and us and East Grenville and the Southeast is leading the way. When I talk to my colleagues in other health units and got that experience from here, one of the keys to success was that relationship with primary care. We were not competing for the same clients and people wanting to immunize. We were looking at that and making sure that everyone has the niche, everyone does what they do best and puts in that effort that adds to that collective outcome that we've accomplished. That was really key and important element. The other important element was when we had to redeploy and maybe do less of some of the routine work that we've been doing. I think that comes to mind is our sexual health program, where there needs to be follow up with cases for various reportable conditions, and they need treatment. That some of that assessment, some of that screening, some of the treatments we're doing, we're not able to do in our clinics, but that's where we reached out to primary care to help us with this, and that really enabled us to focus on other things. And as we move forward, as we move towards the recovery, we recognize that there's really our region has very, very diverse population. Some of them are connected to primary care, some of them are not connected to primary care. If we can divide that work in the most meaningful way, that we do not provide, let's say, a duplicate service for a population that's otherwise really well served, then we are able to reallocate resources to go into do some outreach work and work with partners to reach out to those who are otherwise marginalized population, would not have access to primary care, would not come to our clinics. We're doing that as part of the recovery, and that's really essential to have that relationship with other healthcare organizations, agencies, primary care, addictions, mental health. That's the approach that we take in this region. Another big group of interventions and the category of work that unfortunately had to be put on hold, but it's key from public health perspective, is the overall sphere of early childhood development. So there's some, and this group is very well familiar with this concept that these are really critical years in a person's development, and interventions applied at that level, or if there's problems not addressed at that stage, they could have a profound impact on people's health later on. So the example here, the preschool speech and language and infant hearing program, these are the services that are offered by public health that we continue to provide. We were providing them in some limited fashion throughout the pandemic, but certainly the in-person assessments were not taking place. That was the sad reality of earlier years in the pandemic. Now, this is the one program that is prioritized to restore that level of service that we had and catch up on those who might have been missed earlier on. Along the same line, early childhood development, healthy babies, healthy children program. So this is a program. I don't know how many of you are familiar with this. Okay, don't see. It's a program that's been. It's a different ministry. So normally our programs and funding comes from the Ministry of Health. This one is the Ministry of Children and Youth Services. It's a little different pot of money. It comes with challenges on its own, but what it involves is basically universal screening for risk factors for all children born in this KFL region, but then more targeted and more intense follow-up for families who identify potentially greater risk. So it's intended to provide that increased support to some of the families if they choose to take advantage of this. It basically involves visiting families at home, and that's also something that was put on hold during the pandemic. Families were not at that early times in the pandemic comfortable with others visiting them in their own households, and then the demands of the work were also limiting our ability to provide this service. So now this is restarting. We're looking at even some expansion of the approach, of the scope of this program, looking at initiatives such as the nurse partnership. I forgot the acronym for that one, but it's basically it's evidence-based program where families are connected with a nurse who's going to visit and help them through that time, through that period, and it is known to reduce very significantly some of the risks for both maternal for child health, and is something that is very exciting to plan and implement in this region later this year. Unfortunately, this is a very very sad topic, and we all heard about the opiate crisis, about the toxic drug supply crisis. This is one of the example of things that health problems that was present in this community, present in the province, nationwide before the pandemic, and unfortunately, some of the conditions where we entered the pandemic made this worse. But think about the imaging or the messaging that we had prior for substance use in general, mental health, was all about staying connected to the community, staying connected to people you know, don't use drugs alone. All of that was then countered by the pandemic messaging. Stay apart, keep to yourself, don't really prevent these social interactions, non-essential social interactions, to reduce the risk of transmission. And that, unfortunately, combined with all the stress from all the disruptions that happened in people's lives over the course of the pandemic, all the coping mechanisms that people might have used. And I mean, I'm speculating here, but it is something that's been discussed many different forms. How we believe that the demands, the impacts, the stress of the pandemic resulted in or was associated with increased risk of or increased use of substances. And as a matter of fact, in this region, I believe in 2020, the first year of the pandemic, we didn't have any. I don't believe we had any COVID deaths here. I wasn't here, but when I look at the stats, we didn't have any COVID deaths, but we did have a number of deaths from drug overdose, and that number was higher than the years prior. So certainly something that is impacting already the marginalized population, that doesn't get sufficient attention in the media, doesn't get sufficient attention in the discussions, and certainly needs to be addressed. That's why this is one of the priorities as we enter the recovery phase. And certainly, as this organization is Gateway Public Health, we are leading the Community Drug Strategy Advisory Committee. So that's one of the lines of work in that harm reduction file that we are leading as chair of that group. And we're currently looking at community consultation to gather information to what would be the unintended consequence of potential mitigation if unregulated substances were decriminalized. So that's a really important line of work that happens in this region. And of course, we continue the routine work that Public Health has been doing all along, which is the harm reduction pillar of opiates or drug use strategies, so providing safe supplies, clean supply of needles, providing the loss and reverse the impact of overdose, and continue with that messaging and working with the vulnerable population. Dental and vision program. So this is something that again was a significant disruption for services over the course of the pandemic, and certainly as we had the closures of different types of clinics, that impacted our own services as well. We just had the new program just before the pandemic, the Senior Dental Care Program, that was long awaited and received a lot of good feedback and updates from the community. That had to be, unfortunately, some of it had to be put on hold. our programs, dental health programs for children, the same thing. That was the priority to restore it. Even earlier on in this year, when we're still doing a lot of the case conduct management work that was in high demand at that time, we were already restarting some of this dental screening. And unfortunately, we do see that in schools and in areas that we're screening that the indicators are not improving, and that's really draws attention to the importance of this work. One other aspect of the work that wasn't quite put on hold the same way as some of the other aspects, because we are the only agency that is responsible for case conduct management for non-COVID communicable diseases. So that still had to be done. We still, if there were reportable diseases diagnosis, we're the only organization to really respond to that and follow up with cases, contacts of various conditions. We do receive all of the, we are, by law, the healthcare professionals are obligated to provide us with reports. We get automatic reports from the public health lab. So that's where we respond. That's where we collect data on the magnitude of reportable communicable diseases. And unfortunately, this is something that also we've seen that there was a rise of, I'll use the example of the sexually transmitted infection. There's been a rise of these infections even pre-pandemic, but over the past 2 years, some of the stats that we had 100% increase in our rates of syphilis infections. And one of the really notable indicators is also we have seen our first case in decades of congenital syphilis. So this really speaks volumes to the increased magnitude of risk for some of these conditions in the community. Whether or not and how the pandemic impacted that, it's difficult to say. But it did impact the ability maybe of people go for screening and seeking treatment. So maybe delayed diagnosis. I mean, these different mechanisms have been suggested. But the outcome is our rates are going up, and that's really that is the high priority for us, for public health, to work with our partners at different levels of primary care specifically to address that. Other problems have also not gone away. We talked about, we've always been a hotspot for Lyme disease, but when you think about the Lyme disease and the impact of that, how the pandemic impacted potentially the rates of Lyme disease. Our messaging pre-pandemic was one of caution. When you go enjoy outdoors, this is what you can do to be safe. Stay in the middle of the path, avoid the kind of areas that ticks like to hang out and can get to. Over the course of the pandemic, the key message was stay active as much as you can, use outdoors because that's a safer option than perhaps physical activity indoors. And in that message, we didn't add that additional element. But by the way, when you do that, be careful about Lyme disease because it will do too much. It was all COVID focused, and that was the key message. But certainly the risk has not changed. We are seeing the rates of Lyme disease continue to be very high in this region. As public health, we also added the additional service to our communicable disease and clinical services. It's the pre-exposure prophylaxis for people at risk of HIV infection. This was born out of need where our colleagues from infectious disease from the hospital, they already were struggling with a high volume of consults. So we felt that that was the type of service that was suitable for public health, and we are well connected. It gives us also additional elements of connection to the community, people who are at risk of HIV. So if and whenever, hopefully that strategy does not fail, and they remain unaffected. But if if that was ever to fail, we're already well connected and already have that relationship with the population. This also helped us reach out to those same individuals who might have been at risk also for other conditions when we had the where we offer monkeypox vaccine. So that's that all serves us well, but that's one of the important avenue of work that public health does here. And we are on a 24/7 call for any communicable diseases reports. So thankfully there are not that many coming through the on-call system, but or in general, but there's a steady stream, and we do get, as I mentioned, some of the rates are at the all-time high. Immunizations, again, that goes back to that restoring basic level of protection that we had in that we enjoyed before. There's a number of immunizations that are publicly funded in Ontario. Some of them are required to provide proof of immunizations for school or daycare entry. So public health is the main contact for all of these publicly funded vaccines. So if whether someone gets them from through our programs in schools or through primary care, the ordering and moving of the inventory happens through public health. So that's a significant line of work that we do. And this is also where we've seen some of the drop in routine immunization throughout the pandemic. When primary care offices were encouraged to do virtual care, where there was people were not that keen on really entering and mixing and mingling in public spaces, some of these immunizations might have been delayed. The school-based programs were not they were not continued. So so that's the area where we are prioritizing the in our recovery efforts. Chronic disease prevention. So this is something that when I talk about these categories, these are the categories of priorities that we communicate at various levels. So when we were meeting with the provincial MPP candidates and then MPPs, we were bringing this little summary sheet of these are the priorities for public health. Chronic disease prevention is one of them. Early childhood development, opioid crisis or toxic drug supply crisis were another ones. But chronic disease prevention is something that often loses, or the public may kind of lose focus that this is still the top killer of people in this province in the developed world. And pre-pandemic, we're talking about 3/4 of deaths in Ontario were associated with chronic disease. And chronic disease defined very broadly. So we're not talking about just one particular type group. Cancers to that group as well. And I know that there's quite a controversy how you define chronic disease and which conditions are put into that group. But for the just for the broader communication to the public, we put it all together. And when we still look at the chronic disease and the risk, we're still looking at the same modifiable risk factors that are listed there. So tobacco, alcohol, tobacco smoking, cigarette smoking, alcohol consumption, physical inactivity, and unhealthy eating that really tops the list of these modifiable risk factors. And even though some of these rates might be improving historically, the smoking rates have been going down. I haven't seen if the pandemic had any significant impact on that, but we have concerns about general substance use and alcohol consumption that might have gone up over the course of the pandemic. And that's really something that unfortunately might have become a new norm for what people do when there is perhaps not much else to do. And this is again a significant line of work that public health needs to do. In our discussions with the province, we always say that Ontario still lacks an overarching comprehensive chronic disease strategy, believe it or not. When I say that to some of the stakeholders, they're surprised to hear because we have a strategy on, or there might have been a strategy on individual risk factors and individual conditions, but there isn't really anything overarching. And that's something that's one of the advocacy points that we have with the province is to look at that recommendations from the Auditor General report pre-pandemic and bring that topic back to into the spotlight. We are uniquely positioned in Ontario. We're the only agency that's really truly responsible for health promotion, and chronic disease prevention being one of them. But we need some more support. And the work that we do locally is in the realm of creating more of a population health approach, looking at the healthy environments, working with municipal governments. Simple things like active transportation, public transportation. Again, these may not be solutions appropriate for every community, but if possible, that's something that could make a big difference. And as many of you are well aware, and it doesn't really make a big difference potentially on an individual level, but for the population health of the community, that makes a big impact. So that's our focus as well as we are exiting the emergency response, moving into the routine operations. We've seen the impact of pandemic, and we've seen that this is where we will need to focus our efforts. One big topic we always refer back to is also the food insecurity and income solutions and impact of income on disproportionate impact of that on some of the goods in the community. That goes to our health equity approach, and unfortunately, in this region, we have approximately 13% of households would be considered food insecure, and that's pre-pandemic. So that's even before any of the most recent information came out about the increasing cost of living. We are looking at tools to assess that, but we started already with that income or food insecurity numbers fairly significant in this region. When we discuss with municipal governments and our stakeholders, let's talk about the climate change and health and the connection there. So in public health, we are not really in the industry, in the sector where we can perhaps do more of advocating for the bigger picture solutions of causes leading to climate change. But we are in the business of response and mitigation. So that's where we work with stakeholders. We need to be prepared to respond to severe weather events and see changing patterns of communicable disease. I already mentioned Lyme disease. There is a change in habitat for many of the species, and then we see that that impacts human health. We are also looking at going back to food security or safe food, safe water. We're looking at impact that may have droughts, for example. We had this, it was pre-pandemic, this crisis where people were, basically the wells were running dry, and one of the solutions that we were, not one of the solutions, unfortunately, someone thought of the solution of dumping water into the well from another source. And that's an example of really where we need to increase education. We need to work with operators. We need to work with stakeholders and really raise awareness that putting external water into the aquifer does not really solve the problem. It just potentially contaminates the supply. So, but that was the reality of a few years back when we had that drought in this region. So all of that is very much within the realm and scope of public health, and that's where we see that problem, the pandemic, happened and disrupted the work that we've done in this area. But the problem itself has not gone away, and we certainly see we might get the increased frequency of severe weather events that we need to respond to. So this was just a very a brief overview. There was I apologize for some of the slides missing. There was one more planned before I was thanking you, so I'll talk about that. In general, when we talk about the shift to refocus and strengthen the community, we look at these bigger picture items. We look generally at health promotion, health protection. We look at the population health assessment and seeing the impacts of various conditions on the population. We talk about disease and injury prevention and overall emergency preparedness. These are the key domains of public health. That's something that we are, that's within our mandate, that's within our task to maintain. And our efforts are grounded in this returning to the work of essential public health functions. These were the functions I listed earlier, but it's to remind the public, remind everyone that public health is much more broad than what the public has get to know us. We were in the past, maybe suffering from not being very well known in the general public, and that had its own disadvantages. Now we are very well known as from that key area of control of communicable diseases, COVID specifically. But again, there's much more to public health than that, and a lot of that work is long overdue to be continued, to be restarted, and we're doing every effort to bring that level of protection back to our communities. So with that, I thank you for listening to my presentation here. I mentioned earlier that this really is intended to be a forum for discussions. We want to frame that discussions in a little bit of historical perspective and what we're doing about it. But with that, I turn to you for questions, comments, or any thoughts you might have about this.
So who has questions for Dr. Oglaza? We have a microphone if you'd like to ask him questions. Don't be shy. We have a medical officer of healthcare for our region. We don't have that every day. Yes, in the back.
Hi, what do you think is will be the most challenging public health issue in the next 10 years? Maybe one that you talked about today or emerging?
So that's a really good question, because this is what we try to foresee and see what we can do about that. So there's just one big challenge for public health, and I'm going to frame it in a public health challenge, public health in general, and challenge to public health in Ontario. So in Ontario, there is that returning discussion about what should be the structure, what should be the how public health should look like. So when you look about 10 years, that's the time frame where we might see some maybe renewed discussions about that. And that's a threat locally and in this province, because any kind of change, even if it is for the better, it brings in disruption. And so we've already have a lot of work and a lot of backlog to do. That disruption will have to be done really thoughtfully, so we maintain that level of service. So that's on the maybe more of a narrow sense. On a broader sense, we are looking at some of the trends in our population. So we have the aging population, we have climate change, we have things that impact people's resilience. We talked about the health of the communities and connectedness, and how that helps with maybe mitigating some of the other risks. We all see all these things converging. So I'm concerned that in the next 10 years, we'll have to be maybe dealing with more, just think about more extreme weather events that are impacting an older population that's less connected, less resilient. And there's also that underlying issue of that population needs healthcare, and that healthcare is also in somewhat suboptimal state. So to me, that's the biggest issue. What can we do about that, though? We should be focusing on strengthening communities, because that's where we see a lot of mitigation can happen from people being connected, from communities being strong, from municipalities having plans how to respond to various things. And that's really the focus of our work, is to best prepare us for these coming years.
Thank you.
Dr. Hunter in the back.
Hi, Piotr, how are you? Very nice to see you again. My question has to do with some of the specific activities that KFLA Health Unit might take around health inequities. You mentioned a health equity approach. I'm just wondering, are there ways that you target low equity groups in the Kingston area?
Yes, thank you for that question. Very important topic, and this is something that, in retrospect, I should emphasize more in this presentation, because anything we do, any kind of service or approach we do in public health always has that two-pronged approach. So there's something we do for the general population that's going to move improve the health of everybody. There's that universal approach, but a lot of the services we are actually even moving away from any of the direct services to the general population and focusing on the groups that are already struggling with some of the health disparities. So an example it comes to planning, it comes to program planning, it comes to discussions with partners, and it also comes to planning for service delivery. I use the example of sexual health. So we have this growing, increasing rates of sexually transmitted infections, syphilis being one example. And we used to run sexual health clinics out of our building. These were really well received, excellent clinics that were happening there. And they were open for everyone. So we were investing resources into running the clinics that were pretty much another choice for potentially for people who may have family doctor, might be connected to primary care, might be going somewhere else for care, but we're a convenient option for some, and really excellent option. The pandemic disrupted that. We're not able to continue with that. But as we restart the program, the health equity approach here is, let's look at the populations that are otherwise completely marginalized, that would not have been connected to any kind of care. They barely are connected to the outreach healthcare professionals from Addictions Mental Health program. And they have underlying health issues that are outside of the scope of Addictions Mental Health. If they are suffering from sexually transmitted infections, there's no other way that they really can be connected to care. So our approach to that is work together with those partner agencies and invest our resources into outreach service, outreach screening. We've done medical directives that public health nurse goes jointly with staff from the Addiction Mental Health, and they're offering screening, treatment if positive, follow-up. That's done in an outreach mode where otherwise these individuals will not be connected. And really, this is one example of the program. There's many other approaches where we are refocusing our clinical efforts, our program efforts from populations that are otherwise very well served to the populations that are completely marginalized. So that's in a nutshell what the philosophy, how we approach things. The whole aspect of advocacy for income or food security solutions or opioid crisis is also intended to be bringing attention to those highly marginalized groups that are really suffering disproportionately from compared to the general population, and that's also the focus of our work. So I hope that these few examples answer the question, but that's really everything we do is with that health equity lens.
Hi, it sounds like there's a lot of great initiatives. I was curious about how they're evaluated and how you see their success, et cetera.
Okay. Excellent. Thanks for that question. So this is really something that our teams are striving to do. Is anytime an intervention is intervention is planned, there's an evaluation built into that. So this is something that and there's some things that we have to do, and they're non-negotiable, come from legislative requirements. But even that, there could be improvements made to the processes. So we have a team. Our teams are looking at this from either the CQI lens, between quality improvement, to do better what we have to do anyway, or when we're planning new things, there's always the evaluation element built in, and that really that truly speaks to some of the things I learned in this program, where we're talking about evaluation in some of the courses in what I took. It seems that well, we're reducing the amount of resources we can use to deliver the program, but we're reducing that for a very good reason. Because what if we didn't invest in that evaluation? Then we might be doing something that's perhaps completely off. So that's the mindset of everyone in the organization. This is not mandated. It's our own internal approach, and that's where the focus is for our health.
Yes.
So you might have answered this question before, but to better prepare for potential vector-borne infectious disease and its societal or health impacts, what changes do you foresee in the public governance that are needed?
So with the vector-borne, specifically with the vector-borne, I think this is more about it's less about the governance of public health, because that's sort of it's like a different topic. But in terms of working with partners, working with communities, it is about the first of all, it's about awareness. It's about creating structuring and then building infrastructure, or building designing the land use in a way that even though we are now expanding as a society, we go in housing developments in areas where kind of joining the habitat of other species where we might be not at more risk for vector-borne diseases, for example. But this can be done in a safer way, in the safest possible way. This can be done with a bit of design, and having that awareness, I think it's really key. Having that requirement for that type of design, that's working on the level of municipal sector, for example. That's another way to do it. But it's been done over the course of several years. There's still more to do in this aspect, but I don't think that there's anything in terms of governance specifically that really would make a difference. Continue to have that relationship with the governments, anytime local, municipal. Anytime there is a official plan review, or the municipalities are looking at sort of like longer term opportunity or longer term planning for different undertakings, projects, so on. That's something that we get notified and we are asked for comments. And having that good relationship with being based locally, municipal, having that good relationship with those level of governments enables our team to provide input to what we see. So let's say if there's a planned new subdivision and parks and trails, like we may have some thoughts and comments how to design these trails that it will reduce the risk, and how to create the clearing zones between the habitat and human development. So there's different ways, but the key is to have that relationship. So in terms of governance, I already mentioned that the autonomous type of board is really where we are most connected, in my opinion, because we still have that independence, but we are based in the municipal sector. It's really something that enables us to do that work.
Go ahead, right here, and then we'll go.
Going forward, we're moving away from.
Why don't you stand up, but
Going forward, we're moving away from a physician-centered care approach and towards an interprofessional team. How do you foresee public health playing a role in that transition?
Very good question, and I think we are a leader in this type of approach, because simply a lot of the work that's done in public health clinical work is done under medical directives. So basically, this means that there's certain types of acts, treatments, things that basically are not permitted otherwise for different professions. But if it's done under medical directive, under certain sets of circumstances, that's put in a document, then that can be a delegated act. So we have developed, out of necessity, because that's the nature of our work, we've relied on this for years. And this is something that we are very keen to share with our partners. We have shared that with primary care, for example, or other healthcare, where we really could maximize the scope of practice for every single professional who's working in public health units. And when necessary for legal reasons, use medical directives and do so safely. So in addition to that, we also have the established systems for monitoring quality, for oversight, making sure that this leads to best possible outcomes. So that's, in a way, we are already there, and others can certainly draw from that experience.
Time for a couple of more questions, and I want to take Bren, but first we have a question in the chat on Zoom, Peter.
Oh,
and it has to do with trust. So if you click on chat, I think it's a good question.
Oh my goodness. Don't get me started on this. It's an excellent question. I was hoping someone will ask that. So this is an unending discussion in circles of medical officers or anyone really in public health. I think what we need is, and this is the importance of this group, this program, is to have that approach where we can review what happens, review decisions made, acknowledge that these were best decisions made and under best available information at the time, and learn lessons from that. Some of them might have been good decisions, some of them might have been done from the overabundance of caution, and perhaps there will be not even a change in terms of how things might have been done before. How there might have been we might have not had different decisions if the situation were to repeat itself under the same circumstances with the same information available. But what's really key is that the public segments of the public, they view, for example, the changing advice from public health as a sign of us wavering or not knowing really what the issues are, what's going on. And one day we say one thing, the other day we say the other thing. And what's missed in there is, well, the information has changed. There's new data, new information, new study, new approach. It works somewhere else. We revise our approach. And that is just, that change in advice is being picked by those who are critical of us, and they use it as a proof that, well, public health doesn't know what they're talking about. So I think we have to acknowledge that and maybe communicate better. I know that it's the same thing as I use an example of immunization or vaccine hesitancy. It's somewhat relevant here. There's a group of people who, if they're very firm beliefs and they're on the fringe, they have very low information needs. So there's not much point in spending time with those individuals because their information needs are low. They already are convinced they know what they know, and they will not take it at a point of view. What we can do, where we can make gains, is the population, is the group, is the segment of the population that are still have higher information needs and are not sure. They hear contradicting voices, opinions, and this is an opportunity for us to really engage those individuals in the discussion, be respectful, engage them in conveying, well, this was the situation back then, this is what we knew, and this was the conclusion we came down to. Then we assessed it, evaluated, changed the approach, then the circumstances changed, and our approach was different as well. And I think that's really what some people in the public might be missing, and that's why there's that mistrust, is because they see it as changing stance without really recognizing that the circumstances have changed.
Acknowledge this. So we want to stay on track. We're going to give the last word to Bren, but if you have a question and it hasn't been asked, maybe Dr. Oglaza will stay after for a few minutes. We'll let Bren have the last word and then we're going to take a little break.
That's a big responsibility. So it's somewhat related to Sakib's question and also this trust question, but talk to us a little bit about politics and public health in the context of politics and how difficult it is, or how do you manage when you have political pressures or political decision-making that does not necessarily closely align with public health, like where you might land in your recommendations?
Good question, very related here. So I'll use an analogy from clinical medicine because I find it's really useful. So and I'll get back to politics at that point. So when I work as a primary care physician, family physician, there's often very common type of interaction is with people who may have diabetes, for example. So there's a lot of things that they can do, a lot of things that I have to offer to them as an advice. They should be more physically active. They should probably have a better diet. Here is the medication. Here is the approach. So there's a lot of advice things that they should be doing in order to make their health better. But just because that's my professional opinion that's what they should be doing, there's still that concept of patient autonomy. So they can pick and choose what they want. Like if they don't want to exercise, if they don't want to change their diet or habits, I have to give them the opinion. Well, if you do this, there's a greater risk that your indicators will get worse, your hemoglobin A1C will worsen, and you may have more complication down the road. That's really painting that picture for them. Here's the advice, and here's what will happen if you don't take the advice. But I respect if you don't want to. And some patients clearly may say, no, that's just not for me. That's the patient preference. Now, moving to public health, we're health of the communities, and we don't necessarily get the preferences and opinions from how do we get the opinion? How do we get that voice of the patient who's the community? Unfortunately, unfortunately, in the reality of the system that we have, is that voice of the community is expressed through the elected officials in the democratic system. So if that process leads to the patient being the community or being the political powers not wanting to go for the advice, we still provide the advice, but it's ultimately patient's choice what advice is implemented or what advice is made. And that's how I was able to personally handle the fact that we may have advice that's maybe different than what the action was. Because to me, that action was, I believe that action was representing the preference, the voice of the patient, of the community. And yes, it's not an ideal system. I know there's bigger discussions. Does the voice of the elected, or opinion of the elected official truly represent the voice of the public? But that's the best system we have. So I respect that. I go with it. I'm ready to come back with the answer how to mitigate if something unexpected or not unexpected, expected in that case happens. This is how we can fix it later on. This is how we can do it, but we do it in a collegiate respective way. And certainly this is really where the position, and I don't know, many people may not realize, but there's some change in the structure, the Ontario structure, public health structure, and Ontario government structure in terms of the role of the Chief Medical Officer Health, for example. So Chief Medical Officer Health in the past used to be a standalone function. But then I forgot which year it was, but then it changed into being evolved into the assistant deputy minister position. So that role, there's an element of independent advice, but it's also an element of being part of the administration. So we truly everyone respects and really appreciates the difficult position that even our leadership roles might be happening where there's that part of being the administration basically means that we we speak with the same voice sometimes, and we try to make best of what decisions that we made. And some things our patients, our patients sometimes may not want to go for, and we deal with that. So I don't know if that answered the question, but I think that's
It's an ongoing conversation. I think that's going to have to be the last word. We're going to try to stay on track. Let's give Dr. Oglaza another standing ovation.